me again and shoot those then. Thank you.
Right, so we're all in. Welcome to this this Board of Directors meeting. Can I just start with some apologies, Sarah?
Thank you, David. So we've got apologies from Russell and Glenn, and Adam and yourself for deputising, Phil, Sophie, Jenny's deputising, and Yasmin.
Thank you for that. And before we go any further, I think we got a bit of an announcement that I suspect most of you know, but members of the public may not know, is that Adam has been successful in becoming the acting chief executive for Warwickshire, which I think you officially, was it Monday you became that, or was it?
Yes,
yes, it was Monday. So well done, Adam. And of course, this is because Glenn has taken up a role on an acting basis at the centre. It's a pretty important role within the newly developing NHS. So I think it's quite a feather in our caps to have Glenn at that level, and I'm absolutely convinced he'll make a positive difference, as will Adam, of course, in this area. So can we have any additional declarations of interest that haven't already been? Adam?
Yeah, so as just mentioned, I now need to declare an interest as joint acting chief executive of George Eliot Hospital NHS Trust.
Any others? No, thank you for that. Minutes of the previous meeting, any errors of fact? I see no hands, so those will be duly signed. The matters arising in actions update. First one is complete. There's two that are in progress. Winter plan of vaccination plan, integrated performance report. These are all in progress. Any comments on any of these, Adam?
Yeah, just in terms of Glenn's two actions. So the first is about the 45-minute handover standard.
Yeah,
things have changed there slightly. That
right.
In light of the other changes has not happened. So I suggest we remove that from the action log for now. And in terms of the second action about the soft dashboard,
Yeah,
the changes to NHS England, I think the previous soft dashboard's been put on hold, and we'll expect some changes over the next few months. So I suggest we remove that one for now as well.
I think that's very sensible. Anybody disagree? Sense. So now we are. My remarks indeed. Well, this morning we had a very interesting board workshop. The first was actually a training session where many of the senior staff from the hospital also took part for risk management training, run by three partners from a legal firm, and that was fascinating in parts, was it not? We then had a patient story that actually was a demonstration of how good it can be when everything works really well and the system is integrated. And it was a very good end of life care story, and one that we would hope is replicated, whenever these situations arise. And then finally, we had a session relating to the patient survey. I'd love to tell you all about it, but I don't want to steal Elvis' thunder later on in the meeting. So other than that, I think, again, double congratulations for Adam, and good luck in your new role. So if we can move on, items for approval, please. The financial plan. Kim.
Thank you, Chair. So you'll recall that I took a paper on the draft financial plan to our confidential session last month. This is an update to that position following further discussions at ICB level and national level to improve, to set a financial plan that is acceptable. So in the paper specifically, I've set out really how we have moved from the previously a draft position for SWFT, which was a £29 million deficit, within a system position of a £78 million deficit at the beginning of March. And I then set out really how we've then moved that position to achieve a plan that is break even across the whole system. The key thing to note is that there was a significant amount of money that was held in the ICB at that point in time. Therefore, some of the funding obviously shifted from ICB to the provider organisation. And in addition to that, there has been a number of changes, including a significant amount of further difficult decisions that the ICB are going to make to improve their position, an improved stretch by the providers, an increase in efficiencies, but also an additional amount of money and ERF income that has been distributed at national level. And therefore, we were able to close the gap and set a system financial plan of a break even. Within that, in the table, oh, sorry, I've got the wrong different pages set up on my computer. You will see that that break-even position is made up of a variety of surpluses and deficits by organisation. Within that, the SWFT position is a small surplus of £2.3 million. Now, it's just to remind the board that our statutory duty is to deliver a break-even position, and clearly we were required to try and do a stretch in order to help the system deliver a break-even position, which after much negotiations, Glenn and I and Adam agreed that we would set a slight surplus plan. It is not without risk. And the paper sets out the risks and shared with the board. Since then, the figures of also the income figures also assume a level of income for our elective activity based on the allocations given at system level. Those of you who read HSJ will note that the article in the HSJ today refers to the possibility of lifting the cap on elective activity as well, which obviously from a SWFT perspective gives us more opportunity, I would say as well, which I think is good news, and obviously that will help really us to achieve our plan. Key things as well, I've noted in the report as well the operational targets that have been set in terms of making sure that we deliver the operational targets, and the workforce plan that we've also submitted within that financial envelope. And again, the teams, we've been working with Harkamal and Elva to ensure that we've got triangulation of our plans as well. The paper also includes a copy of our board assurance statement that we are required to submit to the ICP to give them assurance really that we as a board have looked at the plan and that we've done triangulation, and that we've got various mechanisms in place to ensure that any service changes are clinically led, and that we've got appropriate quality impact assessment processes in place to review any sort of decision making around cost improvements or efficiencies, and just to give them assurance really that we've engaged with the board in various discussions. Glenn and I signed this and submitted this board assurance under delegated powers as approved by the board previously. I'm sharing this statement here today so that we've got a formal sign off from the full board to show your support that you have been fully engaged and have been made aware at all times of the financial plan. So what I'm asking next steps is that we have been working with the divisions to finalise levels of cost pressures that have been agreed in order to issue the budgets so that we can obviously hold them to account for delivering the financial plan for the rest of the year. And work has been underway in terms of delivering our cost improvement programme, which has been set at £23.5 million, which is is 5.3% 5% of the target, so 5.4%, sorry, of the target that we had higher target than we had set previously, but again, we've already got some plans in place to deliver that. Relatively speaking, it's a lower percentage compared to many other organisations, but as I said before, that is a stretch target that we've been asked to deliver. What I'm asking the board of directors to do is receive and note the contents of the report and note the risks and assumptions made, and approve the financial plan, including the operational and workforce plan, and note any impact on cash if we don't manage that and deliver that financial plan, but also note and approve the board assurance statement that has been submitted. Thank you.
Thanks for that, Kim. Adam.
Thank you, Kim. Thanks for going through that, and thank you for your work over the last month to get us to this position. I think it's important to reinforce for board members and members of the public, although this is a surplus plan, a small surplus plan, getting to that position will be extremely challenging. And we do believe it's a plan that can be delivered, but as Kim says, it relies on a really significant cost and productivity improvement programme, and we think it's right that we do that and pursue that, but it's going to be tough to achieve this year, and will rely on us making some difficult decisions through the year, I think.
Anyone else got any comments? Robert, as audit chair, I think you're probably going to put your hand up. Yes, you have.
Yeah. Thank for that. And a very clear paper, and clearly a really challenging sort of trading environment as we go forward. I guess the first thing, this is just an observation. I mean, that surplus, as far as I can read, is less than 0.5% of our turnover. So that's not kind of, in any normal year, that wouldn't necessarily be too difficult. Just on the CPIP program, have we taken account of any costs that we'll have associated with trying to implement schemes? You know, if we have to make small modifications or investments or in equipment or working patterns, is that factored in? And I guess a kind of general one about the level of confidence about the scale of next year's program in comparison to any of our previous years.
Yeah, so I think in terms of any costs that are assumed, we normally would take that as a net saving. So if we needed to invest to save, then it would be the net benefit that we would count towards our cost improvement programme. In terms of the size of the challenge, you know, our CPIP target this year was £20 million, and we, you know, identified on forecast delivery of about 16. You know, so we didn't get there in the end. We were fortunate that we've had obviously some non-recurrent benefit support release of balance sheet to offset the position, which has enabled us to hit our break-even forecast, or fingers crossed. Okay, so obviously that's what I'm delivering at the minute. So I think, you know, that there are risks. You know, I think, you know, our challenge is obviously to ensure that we manage those during the year. So I don't want us to kind of not be aware that it is a challenge for the organisation, you know, but the national ask is really high, isn't it? So, you know, and we need to make sure that we do our share of it.
Okay, sorry, Chair. There was just one follow-on which I should have asked in the first place, and that was the degree of confidence that you know, we're not going to be asked to increase our surplus even more if there are pressures elsewhere in the system. Are we on reasonably solid ground that that's the extent of our contribution, or do you think there's any risk of it having to be increased?
At this moment, I would say this is what we've signed up to, so this is our plan. If, just like we've seen in this financial year, if the rest of the system starts to overheat and not deliver, then there'll be pressure across the system for other organisations to either to improve, to mitigate. So, you know, I think it is a risk, because we are, you know, we are one provider within a system, and our obligation is to ensure that we deliver at a system level as well as an individual organisation level. But wherever we can, we will obviously try and make sure that we, maximise our productivity and efficiency to deliver our statutory duty as an individual sovereign organisation in the first instance.
Okay. Any more questions, Kim? See no hands. So this is for approval. So if people are happy to approve, don't raise your hand. So see no hands. So duly approved. Thank you, Kim. Moving on, annual capital programme. Jenny.
Thanks, David. So I'll take the paper as read. The allocations for capital haven't been approved as yet by the national team. So the plan we're presenting today requests approval to continue with the known schemes from 24-25 into 25-26, and a small amount for each of the leads to continue to be able to operate during Q1, which allows us to progress while we're awaiting those outcomes. We'll obviously continue to navigate those discussions about national funding opportunities. And whilst we do have less capital available to us this year, it seems it is obviously fantastic that Ellen Badger and the Community Diagnostic Centre will be finished, and it's clear we need to continue as quickly as possible with the elective hub work as well. So it is a complex capital position this year, but we do have a robust prioritisation process, and we'll be able to further update the board in May once we know the outcomes of some of those conversations and decisions, and understand what, if any, risk this might bring to the programme. Just one small amendment, just for the purpose of the minutes. We have flagged in the paper a red risk that we thought required capital investment around the ultrasound machine at Stratford. Since this paper is written, we have determined that that doesn't require capital investment, so just a small amendment to note there. But today, asking the board to approve the programme, note the priority items that we've set out, and also note the bids that we have submitted. Thank you.
Short and concise. Thank you, Jenny. Any questions or comments on this? No. So should we get some more capital up here? You got well trained plans to spend it, haven't you? So I think we won't be short of things to spend any money on should it come our way. Any idea when we're likely to hear when further capital, or are we not going to hear?
Kim, have you got? So we've submitted our numbers, haven't we?
Yeah, we've submitted our bid, and we're just waiting to hear. And they take their time. I don't know what else to say, really. Clearly, we put pressure on for them to make decisions sooner, because actually the longer they leave making a decision, the harder it is to actually deliver in year. Yeah. So we will be putting on some pressure really for them to make some decisions, but it's been submitted at ICB level now to the regional centre now.
All right, thank you for that. So as with previously for approval, if anybody doesn't approve this, you can put your hands up now. See no hands, so duly approved. Thanks very much, Jenny. Thank you. Code of governance for provider trust. This is you, Sarah, isn't it?
Thank you, David. So the annual review has been undertaken, and proposing that we declare non-compliance with provision 2.7, which is around the independence of non-executive directors, which is explained in the report, but then declare compliance with the remaining provisions of the code, which will be declared in the Trust's annual report. So it's here for approval. Thank you.
Thank you, Sarah. Any questions of Sarah? No.
No, I'm sorry, Chair. Just
sorry,
that,
Robert. Go.
No, it's okay. And as the paper explains, that we considered this item at the audit committee. We're happy to support it.
Thank you for that. Thank you for that. Any other comments? No. So if you don't approve this, put up your hand now. No hands, so duly approved. Thank you, Sarah. Moving on, another one with you, the Register of Directors and Register of Directors' interests.
Thank you, David. So this is part of the annual review process, but to note that both registers do need to be updated to reflect the removal of Glenn and to update Adam's job description as acting Chief Executive for both SWFT and George Elliott. So subject to those amendments, I'm asking the board's approval, and then they'll be published on the SWFT website. Thank you.
Thank you. Any comments? No? So again, if you don't approve this, put up your hand now. No hands, so duly approved, Sarah. Thank you for that. And annual review of key performance indicators, Harkamal.
Thank you. So it's quite a brief report just to outline what the key requirements are as part of the operational planning guidance that was released for 25-26. The number of key performance indicators has reduced overall, but there have been just a few additions. And the only one I wanted to point out was the bit around the RTT and just some changes to that. But as the year goes on and I report against those, we can talk to that in more detail. Those KPIs will be replicated across the foundation group so that we're all consistent.
Anybody got comments on this? So it's a big document with lots of words in, isn't it? Anybody have any reason to disagree with this? Put their hand up now. No hands, so duly approved, Harkamal. Thank you for that. So moving on to performance review and assurance documents. Adam.
Thank you very much. I'll just take board members through some of the highlights of the report. First in the report is the staff survey. I'm not going to steal Elva's thunder because she has a larger item on that later in the agenda, other than to say there's a lot to celebrate and to thank our staff who drive the culture that has supported the positive results there. Secondly, the report highlights the CQC inspection that we had a couple of weeks ago. The inspection was taken from a system, pressures and pathways perspective and focused on urgent and emergency care and our medical wards. I think it's really important to look at that inspection in the context of the demand we've seen, particularly given that system pressures perspective. And as outlined in the report, since pre-COVID, we've seen a 30% increase in attendances to our emergency department and a 40% increase in emergency admissions. And as a result, as we've talked about here before, we've recognised that our ED waiting times are longer than we would like them to be and that our patients would expect. Excuse me. And as a result, we've invested in ED staffing over recent years. But there are other factors, of course, for example, the size of our estate, which complicate matters there. The CQC raised a number of areas of good practice in the immediate feedback from their inspection, but also highlighted some areas of concern and have asked us some further questions. We're in the process right now of responding to those and providing the standard data that comes with the data request following the inspection, and as a result we'll be developing our plans jointly with our divisions. We will provide a more detailed summary and action plan at our next board meeting, but thank you to the staff who were involved and supported that inspection. One of the key bits of feedback from the CQC was how welcoming our staff had been and how quickly we'd responded to things that we'd asked them, so thanks to our teams for that. The next item in the report outlines the changes to NHS England, in particular the abolition of NHS England and the merger of its functions with the Department of Health and Social Care. Also highlights Glenn's new role, as we've mentioned, as Financial Reset and Accountability Director. It is a really important role for the NHS. It's a really important role for us. I think the next year will be really critical in defining the future of the NHS and how it works. And there is a really significant scale to the challenge that we see there. So we'll of course be supporting Glenn to do that job. It's also a really unsettling time for staff clearly in NHS England and also in integrated care boards. And again, we'll be supporting through our role as a lead provider in the areas we are doing that. Paper also mentions the planning round. Kim has gone through that in detail, so I won't mention that any further. The acting CEO arrangements we've discussed are also in there. Just to note that Stephen Coleman, previously managing director of Worcester Acute Hospitals, is going to take a similar role from the acting chief exec across Worcester and Wye Valley now. So there will be 2 acting chief execs in the group, and Glenn will obviously maintain his role as the group chief executive, but has passed on the accountable officer responsibilities to Stephen and I. So good news that we have recruited Ashi Williams as our new Chief People Officer, and she'll be starting with us in August, but I'm sure we'll be attending board and other meetings before then, and I know she's already met a lot of board members. Really good news for us, and we're looking forward to her starting. The report also outlines the outcome of the South Warwickshire Community Rehabilitation Bed Review. So there has been a consultation process run on the location of the beds, which closed last month, as we've previously reported. And over the last month, a decision was made by the ICB's board to permanently relocate the beds to Leamington as per the initial recommendation. And we'll obviously be following that through in our planning and work with staff. The consultation feedback, however, I think was really important in planning our future services, and the report highlights some of the key themes there. I think in particular, some of the work the ICB are looking at facilitating around rural health needs will help shape our community services and our integrated neighbourhood teams as they form. So will be an important part of that. We're also looking at some of the recommendations there around travel and transport to understand if there are ways we can support that in the way we work. I think important to note also that the new Ellen Badger Hospital facility will open later this year. We're really proud of the new development. It will provide for the local community capacity for a greater range of outpatient services and a new health and wellbeing hub. We continue to have some dialogue with primary care to understand if we can co-locate and co-work there, but it will be a fantastic facility. Finally, the report in the More From Our Great Teams section highlights some of the fantastic work that our endoscopy team do. There has been some really great work there, not only to improve the experiences for patients in that service, but really focus on productivity. And I think at times over the last year, we've had some of the most productive usage of endoscopy services in the country. So well done to the team there. We've also recently had a really significant capital investment to replace endoscopes with the latest technology. So I won't go through the detail of that, but well done to the endoscopy team because they are a fantastic service. That's all, but I'm happy to take any questions.
Can I add to the thing with the endoscopy, because it was a significant member of my family has recently gone through the service, and I have to say it all got turned around within an hour of arriving at the hospital, having a procedure and having an interpretation of the procedure and home. So I don't think we can make that much more efficient, to be perfectly honest. It may be just one person, but I suspect that's the norm in the department. So that's a really good positive from first-hand experience. Any other questions for Adam? No? Thanks very much, Adam. Integrated performance reports. Adam, again.
Yes, I'll kick off briefly and hand over to my colleague. So to note, really, February saw the continuing of winter pressures, but it's really positive to highlight that we have maintained some of our highest levels of elective activity despite this and improved some of our urgent care indicators. It certainly has been a pressured pressured few months though. As board members are aware, learning improvement are a really central part of our culture. So it's been concerning that in changing our incident reporting system, we've seen a bit of a drop in incident reporting, particularly it looks like for those incidents that result in no harm. But I'm sure Ellie will comment further on this, and certainly her and her teams are working to address this and ensure that our staff are aware and familiar and able to use the new incident reporting system. In terms of workforce, our focus has continued to be understanding and reducing sickness rates. And indeed, we've got a new sickness management policy, which should be ratified over the coming months to support and clarify some of the procedures there. And finally, to note our financial position, which improved slightly in the month owing to some additional funding provided by the ICB. It was still at that point behind where we'd like it to be, partly due to challenges such as winter pressures and the critical incident we had in January that contributed to an overspend, and also some of the non-delivery of our cost and productivity improvement schemes. That said, we continue to maintain our plan to break even for year end. Those are the highlights, but I will hand over to my colleagues for the detail.
Thank you. So Adam, as you mentioned about the in phase, we've obviously done a bit of a deep dive there to try and work out what's going on. It was highlighted at Clinical Governance Committee, and we asked there that the team maybe did a staff survey just to find out from an end user perspective how it felt to use the system. So hopefully we'll get some outcomes from that. And then we're looking at the training as well. There are other factors to consider in that month's data. So we've changed our processes around safeguarding and deprivation of liberty applications. Previously, they all had to have an incident report. Now they are all copied into safeguarding team. So that would have resulted in a drop in incidents being reported. And in terms of harms, just to clarify, the harms reported is total. So that includes harms in incidents involving staff. And for assurance, the harms to patients hasn't actually increased. It's remained quite stable. And the harms to staff can be various, but they tend to fluctuate month on month. But we will continue to obviously monitor this closely. So unless you want me to pause for any questions on my section, I was going to hand to Bhaskar to talk about the learning from deaths.
Yeah,
thank you.
Send over to Bhaskar, and if there's any questions after that, shall we? Yeah, Bhaskar.
Thank you. Yeah, so I think I take the report as read, and you will see our headline mortality figures continue to drop quarter by quarter, and it's now below the unitary benchmark. And at all times, of course, we've been in the confidence interval that is tolerable. And I think that the board can be assured that the mortality surveillance continues to oversee and supplemented by the clinical governance to deep dive into any signals that come on individual streams. And the learning from death process continues to be embedded as part of this, as is our very tight and efficient medical examiner process, even as we embarked on community deaths being brought into the medical examiner surveillance. So overall, a reasonably assuring report that the board should be cited to and happy with. Thank you.
Any questions of Ellie and Bhaskar? But he's been very restrained this afternoon. No question then. We're moving on then. So over to you, Harkamal, I think.
Yeah, it's me. Thank you. So in February, we achieved 67.6% against 4-hour standard. And our type 1, so there are poorly patients, improved to 64%. So we did see a slight reduction in type 1 activity. The daily average attendances did increase to 257. And we really struggled with beds. So that was a persistent theme throughout the month. I'm really proud to say, though, that our ambulance handover times did improve when you compare the February turnaround times with January. Adam's already mentioned it, but our elective recovery was very strong and our diagnostics were above target. Our cancer referrals did fall slightly, but we have seen some growth in some areas, and I've talked about these before, and I remain worried about head and neck and gynae. Strong performance in out of hospital, with a 2-hour response figure at 87% and same day urgent response at 93%. And then I've included some information about our maternity figures. We saw a slight drop in the number of births, but to be expected with a slightly shorter month. I've included as well a bit of a look back on winter. So I used to do this as a separate slide, but we've included it as part of my update. And we have talked about this quite a lot in previous board meetings, so I won't sort of go over everything in great detail because everything is in the report. But just to formally say that this was the hardest winter in the NHS's history, and SWFT were by no means exempt from that. We had incredible pressure on flow from initial attendance to discharge. We had a lot of governance wrapped around it. We've learned a lot from our previous really challenging winters, and so maintained those channels like of governance throughout the year. So we have a patient flow and home first work really to focus on that, getting patients in the right place as a matter of business as usual, rather than overlaying winter with lots of different schemes that sort of start and stop and don't always offer that resilience. I feel like we're getting much better at using data to make decisions as an organisation, and that feeling of being much more data-led has continued into how we've planned for winter, and using that real-time data aligned with our operational sort of cadence, as it were, in terms of our bed meeting, I think really helped us improve our recovery. We were able to learn in real time where we were struggling and then put in really targeted interactions. As I've said before, the volumes were just astonishing, not to mention like some of the acuity. And then if you overlay that with the significant IPC pressures that we saw with the various strains of flu and then COVID, and at the moment we're seeing quite a lot of noro, just the challenge to the organisation was significant overall. And as we know, we declared our first incident for quite a few years, I think over 10 years, on the 8th of January, and that related to the exceptionally high demand that we were seeing. That said, I think there were lots of positives. We were a very resilient team. People really went above and beyond to try and think of creative solutions. We maintained our elective procedures, which I think, given how busy we were as an organisation, I think that's definitely something that we should be proud of. And our ambulance offload times were the best, some of the best in the region. I've also included as a little section what our plans are for Easter. So we're very worried about Easter. Easter is very late this year. It's very close to the first May bank holiday. There's then not that long until the second May bank holiday. So actually within a short few weeks, we've got quite a few challenges coming. And I've put in our Easter planning. So we've taken all the learning from winter and put that into Easter, because essentially it's the same set of pressures, just a little bit warmer and just a bit more chocolate. So it doesn't necessarily change the way that we plan things. And we talked about that today at Silver, which is our multidisciplinary meeting, just to get assurance that we're on the right track. But as it's in the public board papers and Easter's not for a few weeks yet, if anyone has got any feedback, any members of the public, of anything that seems just bland or obvious and you always wonder why we don't do that, we are very open to feedback and trying absolutely anything we can to mitigate some of the pressures. I'm also linking in with our ICB colleagues around the plan for primary care, because I think truly that is the thing that we really need to be focusing on, prevention and making sure patients are staying at home in order to get us through. That's it from me.
Any questions of Harkamal? Regarding the cancer weights and the effective pathology delays, is there any movement on that? Is there any improvement that you've seen?
No, February, when it's published, cancer performance has taken a slight dip. But March, we look like we're sort of bouncing back. The referral rates have really hit us, so we are still seeing like a significant volume, and the pathology delays are significant. And the integrated care system is feeling that. So George Eliot is saying the same, as our UHCW, and we meet with my team meet with pathology weekly to talk through those patient level escalations to make sure that we are managing patients in order of clinical priority and not losing sight of some of those really long waiters. So by way of assurance, we're cited on it, but by way of concern, it's certainly up there with one of the things that sort of worries me the most. One of the things that's helped us on the flip side is like the other diagnostics that we do. So making those rapid improvements in those other diagnostics means that we are starting to churn through some of those patients a lot sooner, albeit not necessarily hitting the targets in the way that we would want.
Barty?
Yeah, thank you, Harkamil. A really good report, and appreciate the challenges that the team have had. I just wanted to ask you, and I'm glad you mentioned the primary care piece, because what I wanted to ask you is there an exercise that happens across primary care and the acute sector to review winter and then work out the learnings collectively in terms of managing seamless pathways that might help relieve some of the pressures that the acute sector gets? And I'm absolutely confident that you do that within the acute side, but I just wondered, is there an organised way that happens with primary care, including pharmacy and GPs as well as other healthcare professionals? Thank you.
Yes, there is. So we at the ICB do organise a formal feedback session. I've got to say, last year it was a little bit later. We actually did it sort of at the start of summer. Part of that was because winter just extends for so long, doesn't it? And I think one of the reflections is that actually like winter is a thing that we almost describe to think that it's going to be the worst that it ever is, and that's just not true. We are just busy all the time. So the joint UEC urgent and emergency care board that the ICB have put in does exactly what you've said in terms of like trying to capture like some of this intel. And we've been quite keen to inform that. You know, we do lots and lots of look backs, and I think I've just articulated that in terms of we've had our winter, we're using it immediately with Easter. So I have shared lots of my data with the system. Obviously, they have a lot of it on their own, but the next urgent and emergency care board is on the 16th of April, and some of this conversation will play out there. The point around involving pharmacy and general practice, I think, is absolutely vital. We are the receivers of these patients, and making sure that we are all joined up is really, really key. So, you know, I have been pushing for that as well, and continue to do so. To be fair, I'm pushing an open door. People want to be part of these conversations. I think there's just an opportunity to do some of this a little bit sooner.
Thank you.
Okay, Ramjit.
Thank you, Harkamil. Just to follow on Adam's point about staff sickness, and during the winter months, as you know, that increases, particularly acute infections, and our flu immunisation rates remain low. So, you know, planning for next year's winter, what can we do to increase those rates, flu vaccination rates, for example, so our staff are not off?
Yeah, so I totally agree with you. We had quite a comprehensive campaign, and we know the reasons why people aren't taking up the flu vaccine. I'm going to bring Ellie in, who I know has been working much more closely on this. If you can help me answer.
I did agree that the flu program. So we start planning in spring. We are this year. We are going to. We always do a wash up survey, so we're going to do that again to staff to find out why they did and didn't have the vaccine, whether there's anything that we could have done differently in terms of the offer, the way we do it. So we try different things. We try roaming, we try clinics. So this year we've also UK HSA has offered to support public health with our messaging and our programme. And then we've also got some external support with administering vaccines as well for this coming year, which will mean that we can provide more clinics. We do clinics out of hours, nights, weekends and everything else. But if anybody has got a brilliant idea, then I'm absolutely open to hear it. But yes, it is full on from about June onwards. We start planning.
Okay. Let's hope we get a good result from that. Last year was a bit disappointing, I think, in terms of the vaccination rates, wasn't it? Shall we move on then? Elva.
Yes, thank you. So as Adam has already mentioned, we have a very high sickness absence rate across the trust, and we saw that increase again in January from the December figures, from 6.21% to 6.56%. Now this remains a real focus for us because our trust target is 3.8%, so we're quite a bit over, and we know the areas in which there our sickness absence is high in, so particularly out of hospital division, which is nearly 10%, and also we've had the largest increase within our corporate division. So we are doing focused HR clinics within each of the divisions around sickness absence, and working particularly with out of hospital to look at a action plan where we can try to get those down. Now we do see quite a spike within a sickness absence over the winter, so it's not to say it's out of the blue. We're expecting an increase. However, the significant increase compared to previous years is quite a lot higher than we're used to. So certainly something we are focusing our attention on. Now, the main reasons remain the same in terms of stress, anxiety and depression, as well as cold, coughs and flus, and then MSK, so musculoskeletal, and something which are consistently our top 3 themes. Now, long-term absence is the most prevalent in terms of the amount that we're seeing and the significance in the longer term absence compared to short term, but both we are focusing our attentions on. Now, in more positive news, our recruitment is good in terms of our time to hire, remains low, and on average we're looking at 2 days, so that's between the individual being told that they've been successful and sending an unconditional offer letter out. So that ensures that we get people to start as quickly as we can without delay, and therefore reducing our need for bank and agency to cover those roles unnecessarily. Now, our turnover figure, we've always had quite a low turnover. It's remained below 10% for the last 12 months. We have seen a very slight increase from our February data, but nothing to be concerned about, and it remains below our target, which is 13%. Happy to take any questions.
Any questions about that? Ollie.
Hi. Given our significant challenges, are we assured that we're investing well enough in our health and wellbeing offer to staff?
Yeah, good question. We've recently, and I say recently, in the last 11 months ago, we've got a new health and wellbeing lead, and it's been quite refreshing to have him in, because he has reviewed all of the existing health and wellbeing initiatives and offers that we have across the board, and he's looking at where we can refresh those, and we're doing targeted work as well at system level as well as within the trust around mental health support for our staff, because as you can see by the figures, that's the most significant in terms of the contributor towards our sickness absence.
Oliver.
Thank you. Yeah, no, thanks, Selva. It's good to see some of the progress we made. Just following up on the sickness thing and the mental health issues. Is that a trend, do you know, that we see across all NHS trusts? And if so, do you know if there are any trusts which do it particularly brilliantly, whether there's anything we can learn?
Oh, I know certainly from the trusts within our system and within our group, it's the number one reason for sickness absence, something we've seen over the past few years. And it's something which we try really hard. It's quite difficult to provide very targeted support for every single individual experiencing different mental health, but we certainly try our hardest to be able to signpost to get them to occupational health early enough to be able to get any additional support, and we offer counselling sessions as well as our employee assistance program, which can direct them to the right people to have those early conversations to get them back to work. So we do try, and as a system we're working very closely together, so that's the system trusts, on looking at what else we can do in order to be able to focus particularly on that mental health sickness absence within Coventry and Warwickshire, because that's something which is really important. And I think just across the board mental health seems to be increasing, as well as, you know, I think in terms of patients that come into our trust and our staff. So something that we're really trying to be able to put the necessary support in place as much as we can.
Thank you.
No trouble. The other questions of Elva? Kim, finance.
Thank you, Chair. So as Adam outlined earlier, our month 11 position showed a deficit of £3.7 million, mainly driven by operational challenges, as well as underfunding for the national pay awards. We had a bit of good news though towards the in February, where we've obviously been trying to get some more national funding, although no national funding was available to fund the national pay award per se. The ICB did manage to get us a further £2.8 million in order to help us deliver a break-even position. So our focus at the moment has been obviously landing the forecast break-even position for the end of March 25, while we've been doing planning as well. This is the fun time of year really for us CFOs. I think it's fair to say. So we're just moving away to focus on delivering that outturn position of break even, and making sure that we submit the accounts according to the deadline. So that's where we're at the moment. The key things I think to note really in the position is that we are still continue to make some really good improvements in terms of reducing our agency and bank expenditure, and that obviously is an ask moving forward into the new financial year. The other two things to note is our cash position remains tight. We did make an application for PDC revenue support last month, but it was turned down on the basis that we were receiving some extra funding from the ICB. That still gives us a bit of a challenge, so we are managing our cash on a daily basis to ensure obviously that we meet our obligations to our suppliers. The other thing to note, we've literally just yesterday received a formal letter from Julian Kelly, who is the national CFO who's just finishing, who's formally written to the ICB to confirm that because as a system we delivered our financial plans in 2022-23 as well as 2023 and 24, we have therefore met our obligations as a system, and as a result we've had our historic debt of £58.7 million written off, which obviously is a significant achievement really for the system, because it means that that amount is not top sliced from future allocations to the system. So that's a really positive result for the system. So I wanted to make sure that the board were aware of that as well. So just thanking everybody, because obviously it's a collective responsibility to ensure that we deliver our finances and as an organisation, but also within our system as well. So thank you everybody for their support in doing that. Happy to take questions.
Any questions of Kim? See no hands, Kim. Thank you. Moving on, staff survey results. You, Elva.
Get myself off mute. Yes, so you will have seen the report that I have included within the papers. Now, just to clarify for those of you who have joined us today, the staff survey results we do every year, and they're an indicator of our staff experience, and they're really important for us to be able to have as many people respond so that we can have look at the range of quality and safety indicators so that we can look to where we can improve. And it's really important for us to understand that lived experience of our staff that work in our trust, and the risk in terms of that associated poor staff experience results in poorer patient experience, and something which we take very seriously. So that's just to kind of give you a summary of what the staff survey is. Now, for the good news. In total, we had 2,900 staff take part in the staff survey 2024, and that's out of 5,666 staff. So that's 52% response rate, and that's increased by 1% from last year. Now, compared to our comparator benchmarking trusts, which there's 122 acute and acute community trust, we score above the national average response rate for that 50.3%. So that's really good. Now, overall, the results are significantly better than the national average, and you'll see within the paper some very great graphs that will show you exactly in terms of each theme. Now, we have 7 people promise themes, all scored significantly above the average within our sector, and 2 additional themes, which are staff engagement and morale, again, which scored significantly above. Now, out of these 9 themes, SWFT has been ranked as the best in 6 out of the 9 themes, and those are: we are recognised and rewarded, we each have a voice that counts, we are always learning, we work flexibly, staff engagement and morale. Now, for the other 3 that we didn't score the best in, we still did rank significantly above average compared to our benchmarking comparators, and we scored 2nd out of the 122 trusts for we are compassionate and inclusive, 3rd for we are safe and healthy, and 4th for we are a team. So overall, very, very positive results, which we're very proud of. And within the papers, you will also see that for a number of the themes, we have scored significantly higher based on previous year's results, and those are particularly with regard to the themes of we each have a voice that counts, we are safe and healthy, we work flexibly, and then the 2 additional themes of staff engagement and morale. Now, in addition to that, across the Midlands, we as a trust secured 1st place with staff recommending us as a trust, as a place to work, and 2nd, we ranked 2nd for the whole of England for that as well. So this is an increase from previous year's results by 2.6%, which compared to results from 2021 has seen a significant increase of 7% to the 2024 results. Now, in terms of as a recommended place to receive treatment, we've also scored well above average and improves from previous year's results by 1%. We're currently sitting at 79.41% against a benchmarking group median of 61.54%. Now, on to the RES and the WDES. I won't go into all of the details in terms of the report, as it's there for you to read. But although there have been positive movements within lots of our RES and WDES indicators, the most noticeable being the percentage of staff experiencing harassment, bullying and abuse from colleagues. So that's shown an improvement by a reduction for BME staff by 6% from the previous results. And we do need to acknowledge that although we have scored very well, there is lots more work that can be done across the board to show that BAME BME staff are having poorer experience compared to white staff. So something which we need to spend time on and understand in terms of working alongside our networks and staff to look at what actions can be put in place. And we have linkage in with our EDI lead in terms of weaving through our actions around our EDS 22 plan and our EDI improvement plan, which comes to board as well. Now, just to kind of briefly touch upon the bank results. So I've included within the paper around the bank results, and there has shown an improvement across all of the themes, although we didn't get a very good response rate. It remained at 18% compared to last year, which was 21%. So something which we will be looking to focus on for the 2025 staff survey. Now, in terms of next steps, I've just included a action plan within the paper for you to have a look at, and this will be to develop and address all of the kind of improvements across some of the themes that have emerged with regards to the survey. Divisions will undertake their own divisional action plans, and they'll be specific to the results within their areas and their services, and looking to how to improve those overall staff experiences, and those will feed into our finance and performance executive meetings. I think organisationally the trust will be looking to address some of the key focus highlights from the survey, but looking at how we can still maintain that improvement which we have had showing in this year's results. So not taking our foot off the gas just because we've done well this year. And that's all. Happy to take any questions.
I think we should be smiling very broadly on these results, shouldn't we? I mean, it's quite an achievement, but you know, I think it is good to highlight that even though it would appear we're up there in the top one or two, we want to do better, and I think that's something we should continue to try and strive for. You know, and it's easy to get complacent because you get top marks on one or 2 years, but there's clearly some things that you've highlighted that we still have to do. Anybody else got any comments at all? No. I mean, the results speak for themselves, don't they, really? Thank you for that, Elva. Patient experience quarterly report, that's you, Ellie, I think.
That is, thank you, David. So formal complaints, as mentioned in the performance dashboard, we have had some issues with overdue formal complaints, and obviously we take it very seriously. We need to respond in a timely manner and make sure we're learning. So we put some other processes in place now, so there's more oversight of these complaints, and I'm pleased to say that actually the number of open formal complaints that are overdue has much reduced in the last month. So we will continue that work to make sure we keep on top of that. Our new provider for SWFT continues to work with our patient experience team, rolling out across the organisation. We use a variety of methods to get feedback. So we have QR codes, we have paper forms, we use SMS texting. And I've asked them to particularly focus on supporting family health and our out of hospital teams with getting more feedback. I think there are some specific challenges in those areas, so they're going to work with them. Our patient experience group, a number of other groups feed through that just for board's information. So we have got a brief update there from our mental health partnership group, our dementia and delirium outreach team, and our learning disability service, who also report to patient experience. We have designed a poster that's gone through patient experience to encourage people and to join the trust and support the trust in lots of different ways. So a lot of us know about volunteers, but there's also patient forum and other ways they could help. So that group has designed a poster which they hope to start rolling out to encourage our public to support the hospital in any way they can. And I'm open to any questions.
David, you're on mute.
It was bound to happen once, wasn't it? And no questions. So thanks very much, Ellie. We'll move on to the next. Annual report, signings and sealings. That's you, Sarah, isn't it?
Thanks, David. It's just here for receiving and noting. Thank you.
Interesting reading how many times it gets used, to be honest. Anyway.
I think this might be the longest report that we've had.
Yeah, I was going to say, it's because sometimes people lose the seal. It's been that long since they've used it, and it seems it's yeah. Anyway, so moving on, Clinical Governance Committee report for 12th March, which is mine. Take it as read. Any questions particularly? No. Thank you for that. We'll move on then. Board Assurance Framework. I think that's got Adam's name attached to it, hasn't it?
Yes, that's right. I'll take it as read. The report outlines risks in the board assurance framework and our organisational risks as managed by our divisions. It's been reviewed by Risk Management Board. Just to note, obviously, we have new trust objectives now, as we do at the start of each financial year. So the BAF will be refreshed this month and received by board in due course.
Anybody got any questions of this? Seems like not. Adam, thank you for that. Some of ratified policies, that's yours as well, isn't it?
Yes, take it as read. 3 policies ratified, 2 safeguarding, and the trust sexual misconduct policy.
Again, any questions? No. Nutritional standards 6-month report. Harkamal.
Thank you.
We're feeding our patients well, are we?
We are feeding our patients well, and now NHSE make sure that we do. So they've got the 8 standards that they published back in 2022, and as such, and we bringing them here. One of the key points is around having a designated board director. That is me. And I love that job, if I'm honest. I get to do lots of food tasting. And we had, the trust essentially holds quarterly nutrition and hydration meetings. There's a joint food and drink strategy, and we've successfully completed quite a lot of assessments. And really importantly, we've retained 5 stars from the Environmental Health Officer visit and celebrated Nutrition and Hydration Week. We continue to implement new patient feeding menus, and we had very, very good feedback on our the staff meals at Christmas. As of now, we're currently tasting the food, so the executive team will be doing that in a couple of weeks to taste the new spring summer menu just ahead of its launch to our patients. But as always open to feedback.
Yes, yes. So don't you share out the food tasting responsibility amongst the other executive? It's remarkably unfair that you get all the things to taste.
No, I got that feedback. So on the 10th of April, if anyone else on the board would like to attend, we are hosting the next food tasting. So absolutely, I make sure all the executives turn up to that.
Yes, because we might only get the things you like, you see, instead of things everybody else likes. So I think it's really important. Any questions anyway of Harkamal? Again, no. So the Guardian of Safe Working annual report. That's you, Bhaskar.
Thank you, David. I take the report as read, and essentially it summarizes the activity that is going on and reflecting the sharp rise in our resident doctor numbers, which has helped us improve our safer staffing. And while there has been a sharp spike in some exception reports in the last quarter, majority of that is from the surgical division, and there has been a lot of learnings we have done with working through the medical division and the medical rota and replicate that on the surgical side next. But overall, I think this report assures that over the 12-month period, ably guided by the Guardian alongside the admin team, that we are giving our trainee doctors a good experience and respond and report, and it's reflected by the fact that we are not being given any fines or any exceptions from the GMC on this. Thank you.
It's good that we haven't got any fines. Delva, did the junior doctors rate us positively in the staff survey? Or
We haven't delved into the detail that much, but I'm sure they did.
I was just thinking it is something that's be interesting to find out, wouldn't it? Pramjit.
Thank you, Vasco. It's the training doctors, the specialty doctors are all our posts filled for the specialty trainees, or are there any vacancies?
Well, the short answer is we will usually get told 2 weeks before they start, as you would know, Paramjit. So I think within the report, you will also see that we have expanded Magesh, who is doing the guardian role, as the CD for workforce development, which then allows a strategic oversight exactly to respond to such short notice absences. So I think the short answer is there is never a situation where all trainees are allocated for very many reasons, but we are in a better resilient place than ever in having that bird's eye strategic oversight that can reach out to individual divisions and have a bank of able people in our backlogs that we can dip into.
So what proportion are these trust appointed, trust doctors they used to be called? I don't know what the term is now.
Yeah, so this report, of course, only is relevant for trainee doctors within the HEE, the Health Education England. But yeah, we have a sizable proportion of locally employed doctors. That's the term now.
Okay.
And we have gone ahead and replicated the offer that we give our trainee doctors in relation to supervision, in relation to dedicated study time and activity time for their CVs and their experience. And the LED has also got a new nominated lead that's been appointed so that we give them a better induction than the conventional one, including familiarization with the country and the city, etc. So we will capture that, but this report doesn't delve into anything outside of the mandatory trainee status.
Okay, thank you.
Any other questions of Pascal? No. So moving on, we're ahead of time, team. Local Governance Committee meeting minutes. I've got nothing to add to them, but have anybody got any questions specifically on them? No. Any other business? Nobody's let me know in advance. Silence is good on this particular point. Good. So questions from governors and members of the public. We've had none sent in, have we, Sarah?
No.
Those that are here, any specific questions you wish to raise? No hands?
Yes,
oh, hang on.
Yes, David.
Roger. Good to hear your voice.
Yes.
Yeah.
I put it in the chat to give you the possibility of advance notice.
Right.
In the light of the bed review and the fact that ultimately the option has been taken not to have beds at Ellen Badger, but to move them to Leamington, has SWFT reached out to the friends of Ellen Badger who actively campaigned against this as a result?
Who wants to
trying
pick
to
that one
speak
up?
diplomatically.
Yeah, Adam, I think this is your go on.
Yeah, so there was ongoing dialogue throughout the consultation period. We've had a specific session since the ICB board announced the outcome a week or so ago, but we do plan to continue having conversations with the League of Friends there, particularly in relation to the opening of the new building and the facilities going in it.
Thank you.
Any other questions? No. Well, thanks to all the members of the public and governors that have come along. Always good to see you. And thanks for everybody for a fairly succinct meeting. Thank you. We're finishing earlier than planned. Do people want to start confidential earlier than planned? It might be a good move, mightn't it? If it's all right with you, should we just leave it for 10 minutes, say 5 to 3? and we come back for confidential. So thanks very much. Bye.